On this episode of the Dr. Kumar Discovery, we're talking with Dr. Ali Elahi, a board-certified neurologist who specializes in a remarkable therapy called TMS, or Transcranial Magnetic Stimulation. Most of you have probably never heard of TMS. It's not advertised, it's not taught in medical school, it's not taught in residency, and yet it's one of the most well-studied, evidence-based, non-invasive treatments we have for a whole range of neurological and neuropsychiatric conditions. TMS carries minimal risk. There's no anesthesia, no surgery, and no medications involved. And the benefits can be profound. It's been used for depression, OCD, PTSD, addiction, dementia, chronic pain, and even post-stroke rehabilitation. The clinical results in many of these areas are frankly extraordinary. So in this episode, we're going to explore what TMS is, how it works, what the treatments look like, and what patients actually experience. More importantly, we'll talk about when TMS might help you or someone you love, especially if you or they feel stuck, you're suffering, or out of options. For many of you, this may open up a window into a fascinating world of brain health that isn't dominated by pharmaceutical incentives and yet still offers real life-changing potential. So before we dive in, one important reminder. This show cannot be used as medical advice. My goal is to give you the knowledge you need to feel empowered so you can take what you learn here, bring it to your doctor, and have the conversations that help you make the best decisions for your health. Because I believe knowledge is power. And the more knowledge you have, the more power you have. Also, this show is completely separate from my role as assistant professor of neurosurgery at UNC. Okay, so with all that said, let's get into it. Dr. Elahi, thanks so much for coming on the show. I'm really excited to have you here today.
Absolutely. It's also my pleasure, and I'm excited to be here as well.
You're a board certified neurologist who specializes in a procedure, a medical technology that almost no one has heard about, but is surprisingly well researched and very effective at treating problems that have to do with the central nervous system, namely the brain. I mean, I'm a neurosurgeon and I hardly know about this. I mean, it's even though the research is out there and it's all has to do with the medical economy and how it works.
Yeah. Yes.
And if you can make a ton of money off of drugs, then everyone knows about it. It's on every commercial. It's on the Super Bowl.
That's
But
right.
when you have a technology that really, really works, but there's not a ton of money to be made off of, you just hardly hear about it. And so that's what I want to hear about from you today. So can you just start off by maybe telling us what TMS is?
Yes. So you'd be absolutely right, Dr. Kumar, in that there's a lot of technology and a lot of advances in neuroscience that people are not made aware of. And again, this is not uncommon for physicians like yourself, my colleagues, who have maybe heard of it, but they don't really know the whole breadth of its uses. So TMS stands for Transcranial Magnetic Stimulation. So what it is part of an umbrella of treatments called brain modulation, or more specifically, non-invasive brain modulation strategies. By non-invasive, it means that we're not inserting any kind of devices into the brain. We're not poking the patients with IVs. We're not introducing any chemicals. And relatively speaking, it's almost risk-free. So that's where the non-invasive comes from. Brain, obviously, we're stimulating the brain. We're modulating brain function. By that, I mean that we're changing or in some ways optimizing the electrical currents and frequencies of brain cells, and thereby changing for the better the chemical and the connectivity of the brain. And that type of paradigm has been in existence for several decades, but it has been now enhanced, and there's now tons more research, clinical trials, also basic science trials that show the exact mechanisms by which it works. So basically, it's application of electromagnetic pulses to targeted regions of the brain. So the short answer to your question is electromagnetic stimulation of the brain.
Okay. And with, transcranial magnetic stimulation, what kind of problems can you treat?
So initially had done a ton of experiments and trials on mood disorders such as depression. And probably that is the most popular use of TMS even at the moment, even though TMS has now become a viable treatment for many other disorders, which I'll talk about. Depression, i.e., severe depression, that one that does not respond or has not responded to the standard medication treatments, is one that's a bona fide, FDA approved on label treatment. By the way, it's also, to many people's surprise, FDA approved on label for OCD, obsessive compulsive disorder, for smoking cessation of all things. But it has been used and found to be helpful in memory disorders, such as dementia, Alzheimer's. And that's what surprises a lot of patients. Post-stroke recovery, those who have had paralysis of their arms or legs or speech following a stroke, when applying TMS, patients recover faster and more robustly than just with physical therapy or speech therapy alone. So those are some of the most popular uses of TMS. It has been also used for pain management. So patients with chronic neuropathic pain. You're familiar with trigeminal neuralgia, for example, with neuropathic pain from spinal disorders. The use of TMS, and due to its effect on brain modulation and centers and connections in the brain that are involved in pain, has been shown to help reduce neuropathic pain. So there are several uses, and those are some of the common ones that we're excited about and we often see patients for.
Yeah, and that's really cool how broad its indication is in the brain. And just to be clear, this only treats the brain. There's no other part of the central nervous system or body that it can treat.
Well, actually, it can actually be used to treat some musculoskeletal and spinal disorders. For example, you can apply electromagnetic stimulation to nerve injuries in the peripheral nervous system. I've seen it used for sciatic nerve injuries. I've seen it used for upper shoulder nerve injuries with some success. So this goes back to the issue that this is a tool. For example, you used a scalpel to do many things, right? You have tools to do many things. And so we need to make sure patients and people understand this is a tool. How you use it is very important, and can be very much different from clinic to clinic and protocol to protocol. You can excite nerves, meaning increase their activity. You can inhibit nerves through the use of certain frequencies, amplitudes, and rhythms of electromagnetic stimulation. So, by the way, I forgot to mention, TMS is also FDA approved on label for migraine headaches as well.
Yeah. And that's
So,
definitely something I want to talk about later because
yeah,
that is a source of misery for people all around the world.
absolutely. Now, the reason I stress FDA approved, not because I have a lot of respect for the FDA, honestly, but because they have been pushed or overwhelmed with so much evidence that they have been compelled to approve it, because they're often accustomed to approving medications. And when the FDA puts their stamp of approval as on label on a product or a service or a treatment, it means that there's no way they could deny it. There's so much overwhelming evidence, double-blind controlled trials, the highest levels of Class A evidence. There's no way they can argue against it. And so to get that kind of thing suggests that this thing is very much scientifically proven and legit.
Yeah. And if you just, go through PubMed and search transcranial magnetic stimulation or TMS, I mean, there's hundreds and hundreds of papers going back decades
Yes.
with many clinical trials, double-blinded trials or sham trials. And the fact that we've never heard of it, but it's so heavily researched, it just shows you how, we don't hear about these technologies that can make a big difference,
Yep.
but are economically just not major drivers of income for
That's
companies
right.
and
Exactly.
providers. I hope you're enjoying this episode so far. Before we go any further, I have a quick favor to ask. Please head over to Apple Podcasts and take a moment to rate and review this show. It makes a massive difference. Your reviews help the algorithm notice this kind of content, and the more people who say it matters, the more the show gets pushed out to others who might truly benefit from it. All right, back to the episode.
Exactly.
So let's just do this, Dr. Elahi. Because many of us have not heard of TMS, can you just visualize for us what a setup looks like? Because when I bet many people are thinking they're going into a tube like an MRI scanner, but that's not it, right? Tell
Yeah.
us what this thing looks like, what a
Yeah.
person getting TMS looks like, their whole scenario.
Yeah. So basically, it's very much non-invasive. It's not something you go into a tube like an MRI. You're sitting on a chair, kind of like a dentist chair, and this what looks like a ceramic figure of eight kind of plate sits on a specific region of your scalp. Of course, we can go into details of how we use the coil or this plate looking structure and how we target. But basically, it's sitting on top of the scalp and you're watching TV or sleeping during the entire process. Patients often ask, what does it feel like? The most common description that people say is like what actually a comedian, famous comedian who also did TMS said, it looks like a kind of like a shitty woodpecker who, is hitting your head a few times a second. It doesn't hurt. It can be somewhat uncomfortable in the beginning. I've done it to myself many times, and depending on how intense we need to apply it, depending on your scalp characteristics, skull thickness, and so on, it's basically a tapping sensation. And there's now plenty of YouTube videos and others on social media that you can see exactly what it looks like, and people describe it as like a tapping sensation. By the way, the reason I found this to be so fantastic is because I started doing it on my own family members.
What were
I
you
didn't
treating them
trust.
for?
Well, for example, my father had bipolar depression symptoms. My wife had peripartum anxiety. My sister's daughter had ADD symptoms. My father came back again later for memory issues. And the reason I did that is because I wanted to make sure it's safe. And who else to practice on than your own family members, right?
Right. This was before you started your clinical practice?
Yeah, it was just fantastic. My mom said, for the first time, your dad is actually waking up motivated to do things rather than just sleeping all day.
That's fantastic.
And so, I didn't trust just the papers themselves. I went out and did it on myself, on many other patients, of my own patients, family members, and the results were fantastic with little to no side effects. And so I started doing it more and more. I tried to figure out how to perfect it. But going back to your question, it's basically like you're sitting on a dental chair watching TV and someone's massaging your scalp or tapping it.
Okay. And so this figure of 8, this is a magnetic coil, correct?
That's right.
Okay.
So what it is there's a wire, copper wire
Mhm.
that's circling inside this figure of 8 ceramic encasing. And when you pass electricity through a wire, it creates a magnetic field perpendicular to that wire. That magnetic field can trigger a small electric shock, any kind of conductive substance. So the brain, of course, is full of ions, it's full of salts, and of course it works through the use of electrical communication, and so it's a conductive substance. So when you pass electromagnetic field through the scalp, it can create electrical changes in the brain, and it bypasses the skull, so it's not a direct electrical stimulation. Interestingly, there is that too. There's what's called TDCS, a transient direct cranial stimulation. They actually pass a small electric current through the skull like one time, and it does hurt a little bit because it's actual electricity, but we use electromagnetic fields, so it doesn't hurt, and it can bypass the skull easily without hurting the patient.
Right. And from what I understand, that TDCS has been around for a while, and
Yes.
it's just not been as effective as
Correct,
transcranial
correct.
magnetic stimulation.
TDCS, interestingly, yes, exactly. TDCS, interestingly, has good data behind it to some extent, and it can help, but it's not as easily applied. It's not as targeted, and you can't keep repeating it over and over again because it hurts. And
Yeah.
so there's a lot more data now. There's a lot more clinical trials with TMS because it's so non-invasive, so painless, and
Right.
so risk-free. Of course, there are some inherent risks which we can get into, but those are extremely rare.
Okay. So just so the audience understands, when you create this magnetic field and it fluctuates, it has to go on and off, it induces electric current in any type of conductive surface. So if you're driving up to a stoplight, you see that little ring cut in the road, that's a wire, a loop of wire, and your car actually creates a magnetic field. And when
Yep,
you drive over that loop, it creates an electric current that sends a signal to the stoplight, says, "Hey, I'm here waiting."
that's
Same
right.
thing, your brain is full of these changing electrical potentials that send signals through neurons, which are
Yep,
essentially the body's wires. And
exactly right.
when you fluctuate this magnetic field through this figure of 8 coil you're talking about, you're going to induce electric current through the brain. And that
Exactly right.
gets down to the basis of what you're trying to accomplish with TMS, correct?
Correct, exactly right. So think of, those phone chargers that you just place your phone on top of this little circular surface. That's using electromagnetic field to charge your phone. So it's actually inducing electric current through electromagnetic field. When you put your hand on that, it doesn't hurt, doesn't you don't feel anything because it's weak electromagnetic fields. If you put your hand on top of a TMS coil, you actually feel it. You feel a little tiny, tiny tap or electric shock because, again, there are nerves also in your hand,
Right.
and you can feel those. So you hit it on the nail. That's exactly right. Now, if we want to go into detail, how does TMS work? That electrical stimulation then causes electrical release of neurotransmitters. It increases blood flow to that stimulated region. It has been shown to increase certain types of neurotropic factors and proteins, which is in large part how it works for post-stroke and also Alzheimer's. There's new synapses that form. It's just, I mean, these have all been studied through functional MRI imaging, vascular imaging, and even, at the basic science level on animal studies and even basic cell structure evaluations following TMS. So it's very interesting how it works. But yes, the underlying mechanism is an induction of electric current in the brain through the use of electromagnetic stimulation.
Okay. And so by stimulating these areas of the brain, we'll talk about the targets and the different diseases, but you are essentially stimulating a current there, but you're also having some kind of network effect throughout the brain, correct? Because no part of the brain works in isolation. We're
Exactly.
just we're just a bundle of connectivity in
That's right.
between our ears.
That's right. So as you know, we now talk about connections in the brain, not so much isolated parts. Any part of the brain is using connections to perform an operation. When you want to speak, for example, there's the prefrontal cortex activation, then there's involvement of the basal ganglia and other centers and the cerebellum to coordinate the palate and speech movements. All of those have to work in coordination. And there's highway tracks that connect each of these nodes. So when you stimulate this most popular area, the dorsolateral prefrontal cortex, you're actually stimulating remote areas that are connected to that region. And one of the more popular ones is the anterior cingulate, which is directly connected to the dorsolateral.
Very neat. Okay, let's talk about depression because I think that's, you mentioned it earlier, that's the most studied disease that TMS can treat.
That's right.
And depression it affects 1 in 5 Americans at some point in their life. And around the world, it is prevalent. And,
Yes.
if you've ever been depressed, it is horrible. I mean, you feel like you're
Yeah.
stuck in a hole, you
Mhm.
can't get out. We have medications, we have cognitive behavioral therapies, which are effective. But there is a certain contingent of people who, even with cognitive behavioral therapy and medication and optimal diet and lifestyle, don't get out of depression. And it's called treatment resistant depression. And that's where this TMS possibly could be a lifesaver. So,
Right.
can you talk a little bit about that? Who would be a candidate for
Yeah.
TMS?
Well, that is sort of the lowest hanging fruit, meaning that those are easy peasy patients that can easily be treated with TMS. But the usual candidate is the person who continues to suffer from severe depression despite having tried all of what you mentioned, multiple medications, cognitive behavioral therapy. They may have even tried electroconvulsive therapy, ECT, which is the standard shock treatment that we can go into later, and they continue to have relapse and symptoms. To be honest with you, let's look at the data. The data shows that medications work between 30 to 40% of the time. That's just the honest fact. You can get that through very large randomized trials, and even a psychiatrist will tell you that if they're honest. But even out of the 40%, only 20% of that is actual placebo control. There's a placebo effect that
Right.
adds another 20%. So what about the numbers for TMS? If you take all comers around the world, nothing fancy, they just slap this on the left side of the brain. They're not sure where they're stimulating. They're not doing EEG biomarkers, no MRI, nothing. You're going to get between 40 to 60% success rate. And these are patients who've already failed medications. So these are the patients that couldn't respond to medications. So the 40 to 60% is really not comparable, right? Because now you're treating the guys who failed medication.
Yeah.
However, if you add nuances such as, hey, do I know exactly where I'm stimulating? Am I using the person's MRI to navigate? Am I using multiple targets? Am I using EEG biomarkers to kind of tell me what protocol to use? That brings it to 80 to 90% success rate. And as you know, this is unheard of in anything in medicine, let alone depression.
No,
So,
there's no surgery I do that I can say, hey, 80 to 90% chance that this is going to be
yeah.
successful because it just
And
doesn't exist.
it doesn't exist. Look at the trial from Stanford. that was done. It's called the SAINT trial, the Standard Accelerated Intelligent Neurotherapeutic, 80 to 90%. And that's double blind. So no other, there's just no comparison. Now, is it 100% effective? Does it cure everybody? Of course not. But show me anything in the world that is 100%. It just doesn't exist
Not in
because there's so
medicine.
many external factors and so many things that could cause treatment failures. Regardless, in comparison to the standard medications and therapy, it's by far more effective. And guess what? You're not taking medications every day. You're not doing this every day for the rest of your life.
Right.
Try stopping the medication even when it's working. There's a huge relapse. The relapse rate, by the way, for TMS is less than 30 to 40% at the end of 1 to 2 years. And even then, the severity is far less than the original disease. And if they come back and do a few sessions, like maintenance, they're back to feeling great again. People ask me, how come I haven't heard of this, doctor? Why isn't everybody doing this? And I'm like, I know it sounds too good to be true. And I know it's frustrating because you haven't heard about this, but here are the papers.
Yeah. It's all
Here's
out
the
there.
testimonials.
It's all out there in
Uh,
the public domain. All
it's
that
all in there.
inform
You can chat
Yeah.
GPT it.
Yeah. Okay. So, I mean, that's incredible. I mean, the fact that, you can potentially have an 80 to 90% response rate. And I imagine the remission rate, where depression's completely gone, is decent as well, correct?
40 to 60%.
40 to 60% remission rate. That means you're cured.
Remission. That means you're cured. That's a great distinction. Remission rate is unheard of with medications.
Yeah, I know. And if you're taking a medication and you're getting a response, well, then guess what? You're probably on that medication for the rest of your life. And it's important to remember is that with these antidepressant medications, there's big side effects. I mean, sexual dysfunction, which is devastating for a man or a woman. Weight gain, you can have all sorts of problems with disequilibrium, flattening of affect, that's your emotional affect. And these things, people are like, hey, I either take this and suffer, these side effects. I can't get an erection. I'm overweight now, or I sit in the hole of depression. And those are their two choices. Whereas TMS, it doesn't have any of those side effects, and it's potentially more effective, which is incredible to me.
Exactly right. I'm glad that you're in the medical field because those who are not may not realize all these facts. And when we talk about dementia, that becomes even more important because to get the needle to move in dementia is unheard of, right? So
Yeah.
to get
Certainly
even
not with
that,
medication.
oh
Yeah,
yeah,
I mean, medications you take are just to try to basically take a little edge off the symptoms.
that's right. So in the medical field, when we talk about treatments, this is one of the most successful treatment options. You're talking about a treatment that helps, high cure rate, high response rate with zero. I mean, we can talk about potential side effects with almost zero side effects.
Yeah. Okay, so I do want to talk about that. What would be the side effects? I mean, you talked about this little tapping, maybe some discomfort on the scalp. There's some mention of people who have a history of seizure disorder or are on anti-epileptics. How do you address those patients?
Well, there is, as we say, the common side effects and then the rare but potential side effects, right? As far as common side effects, yes, there's maybe mild headaches, which usually go away with Tylenol or ibuprofen here and there. Again, we know that there's FDA approval for treatment of migraine headaches for TMS, so it can't be like a side effect if it's also treating it. So there's some people experience some vibrations of the muscles around the face during the stimulation. Some patients feel fatigue or perhaps mild dizziness. Those are the most common. And then you get it to the very rare. Seizure is listed on there, and the risk is 1 in 30,000. That means that the commonly used prescription antidepressants have a higher risk of seizures than TMS, just to let you know.
Have you ever seen it happen?
I've seen it in one patient who was abusing substances and on a bunch of other medications and only one time. And guess what? Those parents wanted him to come back even after the seizure because they saw huge changes, and we just modified the protocol and we had him stop all the ugly substances he was using. So, out of all the thousands that we've treated, that's one. Now, the issue is that you can treat epilepsy with TMS. TMS has had trials to help with intractable epilepsy, and we've actually seen it here in my office. Regardless, that's one that's listed. Another one that sometimes we hear about there's like 3 or 4 handful of cases of retinal tears or vitreal humor abnormalities or tears following TMS. But out of the millions of people who've done this around the world, there's like 5. So it's very rare.
I don't think I do any procedure, and I definitely don't prescribe any medication that has side effects that low, just to put it out
Yeah,
there for reference. I mean, I've even seen life-ending injuries from aspirin. So, the fact that TMS is so effective with such a low side effect is pretty out of the ordinary for medical
correct.
treatments, I would say.
Exactly right.
Back to depression. So you're stimulating a part of the brain called the dorsolateral prefrontal cortex, which if you're watching YouTube, you can see where I've got my hand, but it's kind of right behind the hairline on this left side of the head. And this has some connections to the subgenual cortex and some other parts of the brain that are underactive or overactive in depression. So when you stimulate this left part of the side of the head, the dorsolateral prefrontal cortex, you're
Yes,
changing this abnormal circuitry, correct? And
correct.
basically bringing these patients out of this abnormal rhythm or brain rhythm.
That's right. That's exactly right. So studies show if you do PET scans, for example, if you do functional MRIs, you often find that there is hypometabolic, meaning low metabolic activity in the dorsolateral prefrontal cortex. So the simplest mechanism of action is you're activating the DLPFC, that area of the brain, and so you're waking that area up, and patients wake up from depression. But when you look at it more carefully, it seems like the connection between that region and remote areas we touched on, like the anterior cingulate, which is a deeper structure, how that interaction plays is abnormal in depression patients. So it changes the interaction between the DLPFC and the deeper region of the brain called the anterior cingulate. And it also has been shown to increase neurotransmitters such as glutamate and also dopamine through the release of those regions of the brain that are being stimulated.
Okay. And just to be clear, when you're stimulating, you're activating this dorsolateral prefrontal cortex, this part of the brain I just pointed to on YouTube. And it is basically reigniting these neuronal connections and changing the brain chemistry. But you had mentioned this one time before. You don't just do this once, correct? You're doing this, you need multiple sessions to reinforce the effect.
Correct.
So
Exactly right.
what does that look like for a patient?
So it used to be thought, and the standard still is, that you have to do this once a day for 36 times. That's kind of like the FDA approved protocol. And that's what's most commonly used. So they come in once a day for about 30 minutes. They get stimulation of this region. It's actually like 36 minutes. And then they do that, 36 times. However, there have been a large amount of interest in trials that are trying to make this more easy and feasible for patients because a lot of these patients are coming from out of town. We have patients sometimes coming internationally. So Stanford did a landmark trial where they did 10 sessions per day. Each session is about 9 minutes. And then they get a 45-minute break. And there's actually science behind why 45 minutes. But regardless, they come into the office 8 a.m. They get this stimulation for 10 minutes each, 10 times a day. And then they do that for 5 days, so Monday through Friday. And they're done on Friday afternoon. And then the studies show, Stanford showed a greater than 90% success with respect to depression after that shortened, what they call accelerated treatment. Nowadays, there have been a lot more trials showing that, hey, you don't have to necessarily do 10 a day. Maybe you do 5 a day on 3 days of the week. Just get like between 40 or 50 sessions done because not a lot of people have the convenience of spending a whole week, doing this. Maybe they want to do 2 or 3 sessions a day for 2 or 3 days of the week. As long as you do between 40 and 50 sessions, that's usually the number. So patients sometimes come in and ask, doctor, how many sessions do I need? I used to try to figure out like, okay, you need 25 or you need 20 based on their history, their brain map or what have you, their EEG. But it's like, it's a crapshoot. You can never be exactly right. So if you want to have the high likelihood of success with a low relapse rate, most patients need 40 and 50. Now,
Okay.
I've had patients who've done more. I've had occasionally patients who've done over hundreds of sessions, not over a span of a week, but over several weeks or months. And the reason is because they felt that much better each time. And these are patients not necessarily for depression. They have other disorders like OCD, severe panic attacks and anxiety comorbid with their depression. So it's a complex set of symptoms and diagnoses. And so they feel better by doing more. In other words, there's no harm with doing more, but that is kind of, those numbers are the standard that has been established.
Okay.
Either 36 or 40 to 50 on a accelerated type of paradigm.
So with this Stanford trial, the Saint trial, you guys basically reduced the treatment time from 36 days down to 5 days.
Correct.
And so these depression patients are coming in for 5 days. They're giving basically their week to get treated.
That's right.
And at the end of the week, what are they feeling like?
Yeah. So, what I have been observing is that they do feel better at the end of that week. However, they feel their best several weeks, like 2 or 3 weeks after the last session. And there's many reasons for that. One is there's actually some reorganization of neurons and connections that occur after the last session. There's, of course, life factors, meaning they get to experience more of this new brain, if you will, and understand how it's different. And so they can report more stories and more circumstances that they are now able to deal with, whereas before they could not. But almost always, patients come back several weeks saying, I feel even better than I did the last day. And there are patients where they feel like, I feel nothing on Friday evening. And then several weeks later, we look at their scores, we look at their brain map, we talk to them, and their wife, everyone is like, this guy is much better. And he's no longer complaining about everything. He's waking up, he's cleaning his room, he's actually motivated to have dinner now with people. He's calling to make appointments. And then so family members and relatives and friends, colleagues see the changes much easier sometimes than the patient, him or herself. And then the patients start to realize, hey, I'm not taking this medication anymore. I'm still feeling okay. I'm still functioning. And then we look at, I use objective findings with imaging of the brain through EEG. And then, so I can see that objectively anyway. But obviously, we're not treating EEGs, we're treating patients. We want them to feel better. So those are some of the common things that I've seen regarding the tempo or course of how they respond.
Okay. And this accelerated protocol, is this based on this idea of theta bursts? When you're in a restful, calm state and you measure your brain waves with EEG, you've got these theta waves that come in around 5 hertz.
That's right.
And is that what you're doing here, trying to synchronize the bursts or the pulses of magnetic stimulation with the brain waves?
That's the underlying theory. Yes.
Okay.
So, quickly, theta burst is basically stimulating the brain at a rate of 50 pulses per second in bursts. There's packets of pulses that run at 50 hertz, and each of those packets is delivered at usually 5 hertz. Hence where the name theta comes in. To make it very simple for patients and viewers and listeners, basically we're compressing a lot more pulses in a shorter span of time. The standard is 10 cycles or 10 pulses per second, but this one is 50. So it allows it to, and the machine has to be capable too. There's some older machines that are not able to do that. Regardless, yes, the theory is that you're trying to synchronize with the 5 hertz underlying rhythm or frequency of the brain. However, that still has not been scientifically established as definitive. That's kind of the model or the theory, but no one really knows exactly why the theta burst works, because there have been other experiments where they do 20 hertz instead of 50 hertz, and there's still some response with that. And it was actually Jonathan Downer and his colleagues from the University of Toronto were able to get the theta burst 3-minute trial, not 9 minutes, 3 minutes of theta burst, found to be just as good as the 30-minute 10 hertz. And so that was FDA approved as well. That's why theta burst actually was approved through his work at University of Toronto. But regardless, there's a lot, as with anything in medicine, there's so much we don't know yet that it could be overwhelming.
Yeah.
But we know a fraction of what we should know. The underlying issue is that ask anyone, how do medications work? How do antidepressants work? And the answer is even more vague and abstract.
Right.
Oh, we increase serotonin. That has not been established either.
No.
Actually, I looked back when I was at med school and undergrad even. I tried to find the papers that showed an increase in serotonin following antidepressants. I couldn't find any. There was some scant evidence of CSF metabolites of serotonin. increasing. But so this whole theory that you're increasing serotonin in the synapse is still theoretical.
Right.
And that's mind boggling because the entire industry for the last several decades has been selling you this idea that we're increasing serotonin, and it has not been definitively proven. I mean, it's just nonsense.
In fact, there's studies that show that serotonin is lower in patients who are on long-term SSRIs, which are selective serotonin reuptake inhibitors. So, this serotonin theory of depression is likely just like what we do in every other disease in medicine. We simplify it so we can understand it because the body's so complex that if
That's
we
right.
try to understand and explain and control for every
That's right.
factor, it's just beyond us to do it. And so we have to
It is. It
simplify.
is.
We have to reduce and figure it out that way.
You know how frustrating that is for patients, right? They're asking you, doctor, how does this work? You're trying to simplify it. And then there's those engineer guys who keep asking those questions. And you're like, I'm sorry, that's all we know at the moment. So it's very frustrating,
Mm.
but such is the state of medicine. But
Yeah.
I can almost bet you that we know far more about the mechanism of action of TMS than we know about the mechanism of action of medications in terms
Yeah.
of depression.
I would say that's pretty accurate. Now, one thing I would say to the audience is that in medicine, if something works and it's got low risk, it's okay to go with it even if you don't totally understand it. Because, when your end goal is to fix a problem, and you don't have to understand every single biochemical interaction to know that I got this treatment and I feel better, or I
That's
took
right.
this SSRI and I feel better. Maybe it's not increasing your serotonin levels. But if you feel good on it and it's not deleterious to the rest of your health, then it's
Correct.
okay. Now, I myself, I'm always for less medication. So that's why I feel like TMS is so promising is because, you get to reduce the amount of synthetic chemicals you're putting in your body to basically manipulate your biology. And I also like the durability of it too. I mean,
Yeah.
that's the thing is that, you can get this treatment 5 days. You could go to Dr. Elahi's clinic, spend 5 days there, and then essentially potentially go into remission or be greatly improved and not have to take a pill every day.
Exactly. So you've touched on so many good points, Ravi. I mean, yeah, I mean you're speaking my language because you're in the same field. But yeah, patients get frustrated with they don't know the exact mechanism of action. Yes, that's our frustration too. But and I say this to patients who ask me about supplements. And of course, I don't prescribe supplements. I don't sell supplements or any of that. However, I tell patients who ask me, "Hey, if you feel like it's helping you and you're not having any side effects, as far as I know, great, use it. But if you're using it and it's not helping and you're now having all these side effects, then it's craziness to continue something, right? As Albert Einstein said, it's madness to repeat something that is not working and keep doing it. So now, with respect to yes, the TMS, I mean that is the best part. It's very safe, high likelihood of success with durability. Does it mean that every single person that does TMS is cured? Absolutely not. However, in relation to what's out there, it has a high likelihood of success.
Yeah. Well, that's fantastic. Let's talk about dementia now, because I know this is an area of TMS treatment that's near and dear to your heart. You've published on this topic and you've treated patients for this. And dementia, I mean, it ruins lives. It not only ruins the patient's lives, but it hurts the lives of the loved ones around them. And you go into this period where you're losing someone very slowly that you love. And at the same time, the stress to take care of them is so great. And anything that we could do to try to bring down the amount of pain around this disease is fantastic. And we have a whole pharmaceutical industry, literally billions of investment, and they've come up with basically nothing on this one. So
Exactly
tell us
right.
what TMS might be doing in this field.
Yeah. I almost feel we should have a whole show on that. However, briefly, as you mentioned, dementia is extremely prevalent. It's devastating and debilitating. I've had family members, my own maternal grandfather had Alzheimer's. It's extremely debilitating. And yes, you're absolutely right. Currently, medications do very little, if any, for dementia. And it's very, very upsetting and disappointing that the FDA goes out and approves these newer infusion treatments when even their own neurologist independent panel said it shouldn't be approved. Regardless, I'm not going to go into that right now.
Yeah.
However, the evidence behind the use of TMS for dementia is very strong. If you do a side by side comparison of trials that have used TMS to treat patients, even with mild, moderate, or severe dementia, and put it right next to the trials that were done using medications, TMS is far, far more effective. TMS has shown to be effective in terms of improving your baseline scores, not just slowing down the progression. I'm talking like bedside scores like mini mental status exam, martial cognitive assessment. These bedside scores improve. Here's the problem: it is not a cure. TMS is far better. It slows down the progression. Almost invariably, every family that I've seen, they come back and say, he's much better. He's much less aggressive, much less agitated. His memory's better. But 6 months later, he's kind of deteriorating again. So it pushes back against the disease and delays it and improves the current symptoms. But we're fighting against a neurodegenerative disease, this monster that is chewing away at the brain, if you will. So, relative to the standard medications, it's by far more effective with zero side effects. So that I think is a big success. And
Yeah.
you and I both know these are debilitating conditions that patients have really no other option. And stem cells are still ongoing trials, but they don't do anything as far as I know.
Yeah.
I haven't seen any papers that come even close to the data that we're seeing with dementia,
Right.
with TMS. So the mechanism, how does it work? So
Yeah.
here, I'm going to share this with you that we're looking into publishing this. You know how you can now look at biomarkers in the bloodstream for helping with diagnosis? You're looking at phosphorylated tau, beta amyloid 42/40 ratios. Those are blood tests, right? We have done blood tests before and after TMS, and we have seen invariably every single time those blood biomarkers improve or resolve after TMS.
Wow.
I looked into the literature to see if anyone's reported that. I haven't seen it yet. So that's why I'm looking into trying to publish that. But every single case of patients, we did their blood test before, we did their blood test after. The biomarkers improved. That means that the metabolites of amyloid and phosphorylated tau have in fact improved down to normal levels in certain cases after TMS. What is the mechanism, doctor? Well, it's been shown that there is increased vascular outflow, and basically the microvascular and the microglial cells that clean up the brain, if you will, become more active with TMS stimulation. So they're basically
Okay.
cleaning out the gunk, the amyloid
Mm.
and the tau more effectively. So it just comes out. And
Yeah.
so I bet you if someone does a study where they do PET amyloid before, PET amyloid after, which is what all the big pharma and their drugs are based on, you will see just as good, if not better, effects with TMS stimulation.
Yeah. Well, just so that for the audience, Alzheimer's is basically one of the hallmarks of the disease is this accumulation of these two proteins called beta amyloid and phosphorylated tau. And these are actually proteins that we normally make. Even young people are making them. But what happens is they accumulate in abnormal levels and they cause neuronal death. And so you start losing parts of your brain because of the accumulation of these proteins. And what Dr. Elahi is saying is that these proteins are leaking out into the bloodstream, leaking out into the CSF, and he can measure them before a transcranial magnetic stimulation and say, hey, look, are they at higher levels or lower levels before and after?
They're higher,
They're
depending,
higher.
and the 42/40 ratio is reversed. But yeah,
Okay.
they're generally speaking higher.
Higher before, and then after the stimulation, you're seeing lower levels,
That's right.
meaning these proteins have essentially been flushed out and recycled the way they're supposed to be done. That's what happens when we sleep, actually. As young people, we
Exactly
sleep.
right.
Our glymphatic system is like the lymphatic system in the brain, and these areas between the neurons open up, and these glial cells essentially flush and pulse out a cerebral spinal fluid through your brain, washing these proteins out. And so you're seeing lower levels after stimulation, which means that these proteins have essentially, some of them at least, have been recycled and taken away, degraded by proteases, and basically you're restoring some normal neurophysiological process with the. So what part of the brain are you targeting with TMS and dementia?
But there have been a lot of good landmark trials. Most common, of course, is still the prefrontal cortex, except we're doing it bilaterally.
Okay.
left and right solar prefrontal cortex. After all, that's where executive function lives in
Mhm.
a way. But we're also stimulating the parietal area, there, the precuneus, which is a more centralized region, and also sometimes we stimulate the temporal lobe. So there was one study back several years ago where they did multiple target stimulation and they combined it with some cognitive training, and they showed that you could really help patients with memory loss and even early dementia. They took that data to the FDA, and FDA, you can see it, it's all over the literature, basically knocked them down. Why?
Yeah.
Their argument was, well, you combine TMS with cognitive training. How do we know it's not the cognitive training? Well, they actually showed that cognitive training alone doesn't do much. But when you combine TMS with cognitive training, suddenly there was a change compared to placebo. They didn't accept that. So it's mind boggling. There have been double blind controlled studies with large populations. There's been several Chinese studies, European studies that show clearly that there's an improvement. I've seen this argument that what about the cost of TMS? Well, I mean, don't talk to me about cost when every infusion of these new medications approved for Alzheimer's costs $50,000.
Yeah.
Every infusion of these newer monoclonal antibody infusions that have been approved FDA for not just Alzheimer's, but even just mild cognitive impairment, precursor to Alzheimer's, costs $50,000. And you're at risk for white matter disease, strokes, and death. You get none of that, none of those side effects with TMS, but
Yeah.
suddenly it's expensive. How's that? How does that make sense?
No, it doesn't. I mean, well, it does make sense because there's not a lot of money to be made with TMS. There is with a monoclonal antibody that costs $50,000 per infusion. So, I mean, we just have to, it's not like we're going to change our system, right? Our American system is run on economic incentive. But if we're aware of it,
Correct.
we can work around it
That's right.
and try to realize, different avenues for accomplishing our goals like TMS.
Correct.
One thing I think it's really important to note here is that the prefrontal cortex is where your working memory is. So, if you've ever known a patient with Alzheimer's, they remember everything from their childhood perfectly. And those old memories are usually stored in the hippocampus and they're recalled to a certain extent when you need them. Your working memory is kind of like your RAM. It's what you use throughout the day. So where did I put my keys? Well, that goes into your working memory. It's not necessarily stored as a long-term memory. Well, if you're stimulating the prefrontal cortex and increasing the conductivity there, I could see how that could alleviate a significant amount of symptoms
Yeah.
because Alzheimer's patients can't remember what they were doing 5 minutes ago. They can't remember the conversation they just had.
That's right.
It's a problem with their short-term working memory that's really causing these problems.
By the way, we do cognitive tests done by the computer. So it's very objective, digitally done before and after for almost even our non-Alzheimer's patients would come in with depression. By and large, they improve cognitively. Now, some argue that, well, yeah, if you treat someone's depression, they're going to do better, which is true. But we've seen patients who have no depression also improve cognitively, which is something that has been super interesting because we are now seeing young, healthy, otherwise normal patients do better cognitively after brain stimulation.
Mm.
So it can actually be a way to enhance brain, to optimize brain activity. And there's been also trials that show that. So it's just a fascinating
Yeah.
field. And yes, with respect to Alzheimer's, we published a case report of a very early onset dementia patient, young woman who everyone thought was depressed because who has depression in their who has Alzheimer's in their 40s, right? No one thought
Right.
she had Alzheimer's. And she would say, "Doctor, I forgot like my password to my phone." And she had young daughters that she was taking care of by herself. And even I was convinced there's no way she has dementia. She has likely depression causing memory issues. We actually ended up doing biomarker tests. She had florid signs of Alzheimer's. She has a variant, very rare, called the young onset Alzheimer's. She had the genetic profile which matched it. And we saw, hey, we were treating her for depression with TMS and her cognitive scores improved. And so we were like, wait, she didn't have depression so much. She had dementia and she improved cognitively. And so that's why we published that in clinical neurophysiology, which was a really interesting case.
And how durable was her effect?
Well, she ended up actually, I had sent her to UCLA. They actually did an evaluation as well. They say, yes, we agree she has Alzheimer's. And I called her husband like 2 years later, and he said that she's still better than she was before, but she continues to deteriorate because of the neurodegenerative process.
But you gave her a significant improvement in her quality of life
That's right.
through the stimulation. There is in depression, there's something called pseudo dementia. And a lot of times people who are depressed, they're like, I think I'm in early dementia because they can't remember anything. And that's a symptom of depression. But you won't have these biomarkers for Alzheimer's when you have pseudo dementia. So, and that kind of differentiates it. And this early onset dementia is a very rare thing. Not many people get it. And it's really great that you caught it, treated it, published it so people can understand that, hey, there's another potential avenue here because the treatments still, even in early onset dementia, are not good.
The reason I thought it was publishable wasn't just because she improved with TMS, because that was already established, but this
Mhm.
was a young onset dementia. It wasn't your typical run of the mill dementia. So that's why I thought this was really unique.
Very cool. So, okay, let's go into some of the other indications. I know we spent a lot of time on depression and dementia, which I think are two of the things that I really want to talk about the most. But let's talk about addiction because it is FDA approved for getting off of cigarettes, which nicotine,
Right.
if anyone's been ever addicted to it, it's the third most addictive drug in the world. Very
Yeah.
hard to get off of. And nicotine, honestly, there's a lot of stuff that goes around social media about, hey, nicotine's a smart drug. It's not, guys. It might have some acute increase in attention, but overall, nicotine and smoking and vaping and all these other forms of nicotine generally destroy your body. It's this powerful vasoconstrictor that basically I see spine issues all the time from nicotine abuse. Wounds don't heal. I won't even operate on a person who's using nicotine because their wound doesn't heal. So overall, it's not good for you. And I think I just wanted to put it out there because health gurus out there who are pushing, hey, nicotine's good for you. Very few situations where it is. And it's very hard to get off of because once it takes a hold of your reward circuits in your brain, you're essentially beholden to it. So how does TMS come into something like this?
Yes, excellent. Excellent question. So, TMS has not only been shown to be effective, by the way, for smoking or nicotine cessation. We have now very strong trials from University of Utah, University of Kentucky, who has shown, and I've seen it here in my office, with respect to alcohol craving or alcohol addiction. So, the way the mechanism is not the same as with other disorders we've mentioned. We actually stimulate a different region. We stimulate the medial prefrontal cortex rather than the dorsolateral prefrontal cortex. We actually have patients get into a craving mode. We show them pictures of smoking or alcohol, their favorite drinks. And then after a few minutes, or usually a couple minutes or so, we use an inhibitory protocol to stimulate the medial prefrontal cortex. So we actually put the coil here and then we stimulate to inhibit, not to excite, the medial prefrontal cortex. And after doing that several times, patients report less craving for nicotine, less craving for alcohol. I had one young man who basically his work revolved around alcohol. Every meeting, whether it be sales meetings or whatever it was, revolved around drinking. And he found himself drinking a lot and he began craving it. So he wanted to see if we can reduce his craving. He also had trouble with attention deficit disorder. So we treated that as well. But we applied this paradigm for the first time in my office, and we weren't sure if it was going to work. And he reported back saying he no longer even craves alcohol. He uses mocktails instead, and he feels just as good. And it was
Mm.
amazing for me because that was my first real patient with these kinds of symptoms who responded, and it was just amazing. So again, people are going to probably think, "Oh, you're saying this is good for this, good for that, this for X, Y, and Z." How could that be? That's why I emphasize this is a tool. You can inhibit certain regions, you can excite certain regions. How you use it is important. So yes, it has been proven to be helpful for cravings, for nicotine, for addiction. We actually used it on a patient who had an eating disorder and had trouble with craving fatty foods. We actually showed images of French fries and chicken, whatever she liked. And we tried to inhibit that region with inhibitory protocols. So it's very fascinating when it comes to addiction. There's a lot of work still being done in that field, but it's showing a lot of good, promising results.
And how many sessions would a patient who's trying to be treated for addiction have to go through?
Well, we saw an effect within 10 to 20 sessions. Now, this patient I mentioned with respect to the alcohol came back and did like additional ones because he felt it was so effective. He wanted to continue. But usually within 10 to 20, we see an effect.
And are these the rapid sessions or these are full days?
No, these are rapid sessions.
So they come in for 10 to 20 short sessions and see
Correct.
improvement. Okay. So let's talk about chronic pain, because that's
Yes.
another thing. Oh, if you've ever had chronic pain, it totally destroys your life. In fact, there's people commit suicide over chronic neuropathic pain because it's so bad. Classic examples are trigeminal neuralgia or tic douloureux. You can get chronic pain in anywhere where there's a nerve that's injured, essentially.
That's right.
What role does TMS play in chronic pain?
Well, I mean, you can pull up the papers. It's very clear. They stimulate the motor cortex. So they stimulate the motor cortex here in the vertex of the brain. And if you actually stimulate it at 10 hertz, patients with neuropathic pain after a few sessions report less pain. So the mechanism is thought that, as you may know, Ravi, the motor cortex plays a big role in pain perception. And by the way, this is the same mechanism by which migraines are treated. We stimulate the motor cortex that's at 10 hertz, and we see a reduction in migraine frequency as well.
Okay.
With migraines, we also stimulate the occipital region as well. But regardless, we see there's been large trials for neuropathic pain specifically. For example, phantom limb pain, neuropathic pain such as trigeminal neuralgia, post-stroke neuropathic pain. As you know, a lot of patients after stroke develop neuropathic pain in the area that was injured, and we see significant improvements. Now, I'll be honest, they're not zero. The pain doesn't come back to zero,
Mm,
but it goes down by like several notches. And just to
right.
do that and to reduce their overall opioid or narcotic or other harmful medication use is a big win. So, from what I've seen, while it doesn't extinguish the pain completely, it does reduce it by a good factor.
Yeah, and I've done a few of these procedures where I've actually cut open a person's scalp, taken off their skull, and implanted a stimulating grid over the motor strip to help with neuropathic pain. And to get to that point where you're going to implant a device in someone's brain, they have to be in a lot of pain. And you can imagine these people are miserable. And this phantom limb pain you're talking about, they've had an amputation and they feel pain in a limb that doesn't exist. Now, you can imagine how that could just totally destroy someone. And that's why they call this phantom limb pain, because there's a phantom limb that is hurting you. Well, stimulating the motor cortex somehow improves that pain. And to not have to open someone's head and implant a device and instead do it with TMS is pretty extraordinary, in my opinion.
Yeah. So, Dr. Kumar, I mean, patients often don't realize opening someone's skull is not just like a simple intervention. You're risking blood, issues, infection, and you know better than I. And
Yeah.
so, and then recovery time. I mean, to be able to do this non-invasively is just huge, huge advance.
Yeah. It's huge. I mean, that's where the future is, honestly, because someday we'll look back on what the kind of procedures I do right now. We'll think, gosh, that was barbaric. They cut open people's skull and put, electrical wires in there. I mean, just this week alone, I was deep into the center of a poor man's brain because he had a big old tumor there that I had to remove. And that's the technology we have. But there's emerging stuff coming out. I mean,
Yeah.
there are implantable lasers that we can ablate tumors with now. And now we have this, we have transcranial magnetic stimulation, which can accomplish things that we still have for the last many decades have been opening the head to do.
Yeah. Yeah. So, Ravi, for example, by the same token, or treating Parkinson's now more and more commonly with deep brain stimulators, right? You're
Right.
implanting electrodes inside the
Yeah.
brain, which I think is fantastic and I think it works great. However, we can come close to that, believe it or not, with TMS for Parkinson's.
How are you doing that? Because we implant these electrodes deep in the brain, in the
Yeah.
thalamus.
That's right. Well, I'll be honest, it probably doesn't work as robustly as the deep brain stimulation. However, we've seen clinical trials, and I've seen it again clinically in my patient population here, where we can reduce the tremors by stimulating, again, there are several targets. One is the motor cortex, one is the supplementary motor area in front, and another is the premotor cortex. Those are the three common targets, and usually it's inhibitory, but we can also sometimes stimulate the cerebellum as well, although that's less likely helpful in terms of Parkinson's.
Okay.
So we've had patients with Parkinson's who actually did improve. I would say probably not as robustly. as placing electrodes inside the thalamus or the subthalamic nucleus as you do. However, you're talking non-surgical versus surgical and having to replace the batteries and deal with all the potential complications of insertion of material into the brain.
And those, there's hemorrhages, there's infections. The DBS, these deep brain stimulating systems, get infected frequently. And then there's sometimes it stops working. You go through all this and then it just doesn't work anymore. On top of that, it costs over $100,000 to have this system installed. And in a significant amount of suffering, because it's not painless. We have to implant battery packs over the chest and run wires under the skin all the way up to the top of the head. We have to drill holes through the head. It is a big ordeal, tons of money, tons of suffering, and it's effective. There's no doubt that it's effective. But if you can do all that with a visit to your outpatient neurologist or psychiatrist office, and I know we're at the beginning of this therapy, and as our knowledge improves, man, what could we do? Could we get rid of
That's right.
DBS altogether by modulating through magnetic fields or ultrasound or what other non-invasive technique we have?
Medtronic is not going to like what you're saying.
I know shareholders don't either, because that's a lot of what drives this stuff.
But as I always say, Ravi, there's always a role for medications. There's a role for these surgical procedures as well. However, we should not be ignorant of these other options. And so patients should be informed of, yes, you do have these options, and this is the risk and benefit for this. These are the risk for benefits of that. And they should be well informed. I have seen patients with DBS do well, but also there's risks with that, as you just clearly pointed out. Not to mention that a lot of patients with underlying memory issues are not even candidates for DBS.
Right.
That's one of the contraindications. And so a well-informed patient should have the option of choosing between all the different invasive and non-invasive options.
Yeah, absolutely. I totally agree with that. Let's talk about migraines, because you mentioned it earlier. Migraines are very common, obviously, and we do have good medications for migraines, and we have even some newer injections that are
Yes.
fantastic.
Yes.
What role can TMS play in managing migraines?
Yeah. Well, as you say, migraines are extremely debilitating and prevalent. As neurologists, it's like we see migraines all the time, and there are a growing number of very good treatment options from a medication perspective. I think Botox is also very effective. Botox is FDA approved for migraine prevention as well. With respect to TMS, TMS has shown to treat both acute and prevent migraines. So it can be used for both acute and prevention. For the acute treatment, meaning you just had a migraine and you need something now, there was a company that made a very simplified TMS device that basically triggered a single transcranial magnetic pulse delivered over the occiput. So patients would place this over the back of their head, push the button, and it would deliver that pulse. And it did cut down the migraine severity. However, apparently the company went out of business. um, for whatever reason, probably because not a lot of people knew about it, and insurance wouldn't cover it for whatever reason. And we actually do that, except with the kind of the industrial size TMS, where we stimulate both here and the motor cortex again to help both prevent and treat acute migraines. And for the most part, it's just as good as many of the medications out there, meaning it cuts down the acute migraine. It does help prevent migraines. On the prevention side, it's probably more effective in my view, because I've had patients who came in saying they didn't come in for migraines. They came in for depression or something else, but they also said they have migraines. I try to treat everything as much as I can. So I also add in the protocols for migraines with their TMS. And when I call them again, or when I talk to them again afterwards, they're like, yeah, I haven't had any migraines since I've been here. So, and they were having it like every week or every day.
Yeah.
So it is very effective, but it may not be cost effective because you can't do, my TMS every day or every week. However, I do think it's a viable option. And it just speaks to the fact that these mechanisms of action are very much effective, and they do have profound positive impacts on brain circuitry. And we know migraine definitely involves abnormal circuits in the brain.
Yeah.
So, yes, it is FDA approved. It is a definite viable treatment. However, nowadays, I just do it as a comorbid bonus, if you will, for patients who come in for other disorders. We're not just treating migraines.
You wanna, kind of go over the other indications for TMS, like OCD,
Yes.
PTSD, even post-stroke, rehabilitation, which I think you talked a little bit about
Yeah.
already.
So post-stroke, let's jump into that real quick. Patients are debilitated. Imagine having half your body paralyzed, and there's been an intense amount of research, tons of money trying to find that compound, that medication that is going to help increase the rate of recovery. And none of those trials have ever been successful. What has been
Right.
successful is the use of TMS. The way it works is when you have a stroke, when one part of the brain is injured or dead, let's say the left, or in this case, the right side of the motor cortex. Well, the left side is overcoming the left side through cross inhibition. And so what happens is the other side doesn't allow for the injured side to recover well. So we apply TMS to basically quiet down the overactive side or the healthy side so that the injured side can actually recover faster. Put it
Mm.
simply, we actually help the brain recover faster by stopping itself from injuring itself further. Having said that, the actual clinical trials show that patients recover faster, meaning, especially with hand paralysis or arm or limb strokes, they are far more able to do things with their hand and arm at a faster rate than without TMS. So, for example, if it took a year for the patient to recover, it now takes 6 months to recover. And so
And
we've seen that
you're stimulating the non-stroke side of the brain.
stimulating non-cause. Although there's been trials where you stimulate the injured side as well. And so I've done it both. I've done both inhibitory to the healthy side and stimulation to the injured side. But also remember that these patients also suffer from immense amount of depression
Yeah.
because they sometimes are otherwise healthy people. By healthy, I mean they were moving and no problems with their movements, and now they're paralyzed. So they become extremely depressed. So we actually stimulate the prefrontal cortex as well and try to recover from their depression. So it has become so good in terms of its evidence that many countries in Europe use it as standard of care. For example, I know in Russia, it's just like, yeah, everyone after stroke does TMS. It's like normal.
Yeah.
And many parts of Europe are doing it post stroke as well.
And what kind of results have you seen personally with treating post-stroke
I've
patients?
seen I've seen basically patients have increase in their what we call Fugl-Meyer scores, which is a way to measure hand movements and strength. And I had one patient with a huge hemispheric stroke, chronic stroke, who after we did TMS, and she had been through everywhere. She was from a wealthy family. She had gone through the entire world, Mayo Clinic, everywhere you could think of. For the first time, her family and friends told me this person is a whole new person. She speaks better. She's much more alert. She does move better. So that's kind of what I've seen. In terms of the actual movement itself, there's some improvement. I'll be honest, it's not like a night and day difference, but there is some improvement. And
So
again,
what's the
yeah,
thought there? I mean, if that part of the brain is dead, is it the thought that maybe there are some surviving portions of the brain that are just not allowed to come in and recover?
that's it. The penumbra, the surrounding areas that are still able to fire are made out to fire more effectively. So the few cells that are still healthy around the injury, as we call it, the penumbra, are still able to take over the injured side, the injured cells.
So you're basically allowing that patient to realize the potential of what they have left. Whereas
Correct.
without it, it's very difficult to do it because of this theory of cross inhibition, where the healthy side of the brain is basically overriding the motor
That's right.
input
That's right.
outputs of
That's
the other of the injured side.
right. But you have to kind of block the healthy side from being overwhelming towards the injured side. I think there's more to it because studies show there's increased blood flow,
Okay.
and that by itself helps increase protein synthesis and synapse synthesis, and that's been shown. So the mechanisms have not been fully clear, but those are some of the bona fide proven methods. The cross inhibition, the increase in blood flow and synapses. So yeah, I mean we see improvements in the research trials. They have seen improvements in their physical therapy measurements, like I mentioned, the Fugl-Meyer score and other objective ways to measure strength and mobility. We're also talking about pain. A lot of patients, as you mentioned earlier have post-stroke neuropathic pain, and that also improves as well with
Okay.
these types of treatments.
So, at what point after a stroke would a patient want to start with this? Because there is this period where you have the most plasticity because there's this potential for recovery, and then you start forming glial scars, and your
Exactly right.
potential goes down. So, when should they start TMS after a stroke?
As soon as possible, like within no later than 3 to 6 months. The earlier, the better. Now, unfortunately, the patients, a lot of them, because they didn't know one that I existed, they didn't know that there was this. So it was like several years. But if we can get those patients right after the stroke, it's going to do far more help for them. It's going to do far more than if we get them a year. This patient that I was telling you about was several years, like 5 years, 10 years later. And
And you
even
and
she had improvement. If we can get them right after the stroke, which is what a lot of the vast majority of papers show, that's the key. We really
okay.
can, as you mentioned, there's a higher level of plasticity at that moment, at that period of time and stage than the chronic stage.
Now, let's move over to PTSD. Do you treat patients with PTSD? Because this is an extraordinarily difficult neuropsychiatric syndrome to treat.
Yeah, PTSD is very much a bread and butter for TMS as well. There was large trials, especially in the veteran population. There was VA trials and many other trials. And yes, it's been proven to be very helpful. Again, we stimulate usually the right DLPFC, not so much the left DLPFC. And sometimes we stimulate also the visual cortex as well. By far and away, these patients are placed on antidepressants and they go through therapy. Not to downplay those, I think they do help, of course, but more often than not, they end up continue to have symptoms. When you add something like TMS to the rest of their treatment, it's a big game changer. So PTSD is a big one. And
Yeah.
again, there's certain protocols. It's more effective than the standard one size fits all that you use for depression.
Yeah.
So PTSD is a big one.
You're not having these patients come off their meds, right? You're treating them at the same time as so they stay on their PTSD
Stay on
medications.
whatever they have.
Okay.
Yeah, exactly. We never take patients off medications right away. We do help them come off slowly or taper them in a structured manner after they've improved because some of these medicines were either ineffective or causing side effects. In some
Okay.
cases, in the toughest cases, the medicine wasn't really working before, but after TMS, the medicine seems to be working far better. So we keep them on it. Yeah, it's case by case basis.
Yeah.
But in some patients, I mean, there are a ton of medicines, none of which were working, causing side effects. So we almost always reduce their medication load, if not eliminate it. But
Okay.
afterwards, not before.
One thing I've definitely in social media, but the literature supports it, is this use of psychedelics for PTSD with a guided therapist can help make significant improvements in PTSD. Are we seeing like similar efficacy with TMS?
Yeah. So first off, psychedelics do work. However, you can't take them all the time
Right.
because you develop tolerance, you develop hallucinations, and many other side effects. A lot of people have GI disturbances. There was a large study in the New England Journal of Medicine, very respectful, internationally known journal, which compared mushrooms with Lexapro for depression. And Lexapro or mushrooms did well, but they had all these side effects. So, with respect to PTSD, yes, it works just as well, if not better, without those side effects as far as TMS goes. So, I mean, that one is also a low hanging fruit. It's a no brainer.
Yeah, that's remarkable, honestly. So if you did get hallucinations from TMS, then it would be much sexier though, and people would want to do it.
That's right.
You'd hear all
Exactly.
about it all the
I
time.
know. I almost wish that it did that, but it doesn't.
Yeah.
This is what I tell patients, which is very important because some of the younger patients, especially, they're like, I don't want my personality to change. We're not changing your personality. This type of treatment is not so powerful to change your entire brain. We're using small electromagnetic pulses to tweak small areas of the brain.
Yeah.
And it's not going to make you all of a sudden super happy or hallucinate. It's not a hallucinogen. It's
Yeah.
not a drug. It's not a substance. It basically reestablishes normalcy to brain structure and brain chemistry, not
Yeah.
going to suddenly make you this super happy human who's always happy no matter what happens. You're going to
Yeah.
have normal emotions, which you're supposed to.
Right. And, I would just mention that one of the treatments for resistant depression is ECT, which stands for electroconvulsive therapy. And I've seen it, and It is crazy, the craziest thing to see. You basically take a patient, you put them in a sedated state, and then you take 2 electrodes, on both sides of the brain. Back when I watched it was on both sides. Now I heard they're just doing right side. And you shock the brain and send the person into a tonic-clonic seizure where their whole body is convulsing. And you let that go for, 30 seconds to a minute, and then you give them a medication to stop it. And you do that a couple times, and then you wake them up. And basically, depression gets better. They stop wanting to commit suicide because oftentimes it's used for suicidal depression. But there's cognitive consequences to this, So you're basically shocking these people's brains, trying to create some rewiring, and they start having memory issues. They can have flattening of their personality. That's a big one, and that's all to try to treat depression. And TMS doesn't have any of that. And
Exactly
we
right.
weren't doing it in the psych ward when I was in medical school.
That's right. So actually, TMS has been compared to ECT. It's just as effective, if not more effective in certain cases, and without all the invasive procedures and side effects that you're exposed to. However, I will say this, Ravi, that in the occasional patient that is not responding to TMS, I'm left with no choice but say maybe you should try ECT.
Yeah.
However, the vast majority do respond well to TMS.
Okay, so the last thing I wanna mention before we start to wrap up is OCD. Is there an indication for TMS and OCD?
Absolutely. It's on label, FDA approved. But I will tell you, it's one of the toughest things to treat. One of my first patients, and this patient, it was kind of like I will either continue doing TMS or I will stop, depending on how this patient does. This guy had gone to everywhere, UCLA, the best of the best for his OCD. And it was severe. He would wash his face with bleach because he had germ obsessions.
Oh,
He
wow.
couldn't go to an interview because he couldn't park the car the exact right way, and he had compulsions. He also had comorbid bipolar depression as well. So it was one of my first patients. We did multiple targets. We did, I think, 41 sessions. In that time, we actually used functional MRI also, and along with EEG to guide the treatment. For the first time, he actually became functional. He was so happy. His father gave us a testimonial. Several years later, I'm talking like 6 years later now, he still calls me and says, whoever you want to treat, tell him to call me. He has been our poster child. And he invited me to his wedding, he's married now with 2 kids. He wasn't able to work. He's fully functional. His father was like, you saved my son's life. It was one of the things that stuck in my mind. And to this day, I think he was one of the reasons I continued to pursue TMS because it changed his life so much.
That's incredible.
So, obsessive compulsive disorder is extremely debilitating. Yeah, we all have OCD traits, but those who have the disorder are so dysfunctional that, and the medications do nothing, by the way. The relapse or the response rate with medications is 20%. And so those patients are desperate. And TMS does provide an answer. It's one of the toughest things to treat. You have to do it over and over again, do it right for it to work, but it's far better than the vast majority of medications. Some of them do need a combination of meds with TMS for it to work well, but it is a big breakthrough for those patients.
And what kind of response rates are you getting?
So we're getting between 60 to 80% response rates,
Oh, that's incredible.
not as high as depression,
But
but
still.
the vast majority do respond. And for those that don't respond, by the way, at my clinic, we never give up on patients. We talk about other methods, neurofeedback, combining it with maybe other medicines they haven't tried, maybe even deep brain stimulation or ECT, but that's rare. We almost never have treatment failures to that extent. Sometimes we do a functional MRI to find out where else we can stimulate, but those are challenging patients.
Okay. Yeah, but that's incredible. The 60 to 80% response rate in OCD. I mean, you're beating any other treatment on the market by far. And, a lot of people have mild OCD. The ones with severe OCD, they're, like you said, completely non-functional. Like they can't function in the world. To give someone back even a little bit of benefit is incredible, honestly.
Yeah, we haven't even touched on tinnitus.
Oh,
Tinnitus
yeah.
has actually a lot of good data behind it. I will be honest, it doesn't cure it. So patients still have tinnitus, but it's far better. And nothing else was touching the tinnitus. That's ringing in the ears for
Yeah.
people who don't recognize that word. So yeah, we stimulate the auditory cortex, inhibitory, and It's definitely better than nothing, but those patients are thankful.
So, and is this for patients with sensory neural hearing loss?
No, I mean, they could have tinnitus too, but any tinnitus. It doesn't have to
Any
be
tinnitus? Okay.
sensory hearing loss. Yeah.
So for the listeners, tinnitus, you might have heard it pronounced tinnitus too. People get to pronounce it however they want, really, but it is ringing in your ears, and that sounds like not a big deal, right? Well, when you have a patient, and I know this because I've had a lot of patients with tinnitus, they come in and they are miserable. And they are like, just anything you can do to make this stop because they've got this ringing. Sometimes they call it roaring, or, they feel like the wind is just blowing in their ears constantly. And it drives them literally crazy. And, there's medications we can try, but really, unless you can find, for me, a structural reason why it's happening, there's not a good treatment for it. And
Yeah,
oftentimes as patients age, they start to lose some of the function in the auditory nerve, and the brain's like, it's not picking up the signal, and it says, "Hey, what do we do?" There must be some background noise. So it creates this auditory signal that really drives people crazy. So
exactly.
you're able to basically quiet that part of the brain that's picking up this lack of signal and
Yeah.
basically creating
So
white noise.
that's right. So basically, the response rates that we've been able to achieve is between 20 to 50%.
Wow.
Uh, so when we use a tinnitus handicap inventory, PHI. When you look at their post-treatment scores, it's about 20 at the lowest to highest 50% reduction. However, it's not a complete cure. Patients sometimes, when we talk about these treatments, they're like, but I'm not cured. And we have to say, just to get this is just nothing short of a miracle.
Yeah. Yeah. And oftentimes there's other treatments that you can do too. Sometimes a hearing aid by itself will
That's right.
will help.
There's
Yeah.
noise canceling hardware. I
Yeah.
heard one, I forgot the name of, is quite effective. Again, they're getting the same kind of rates, 20 to 50%.
Yeah. Okay. Very good. Okay, before we kind of wrap everything up, can you walk us through a case study of a patient? Let's go with depression if you wouldn't mind, because I think that's the most salient issue. Let's do this. Let me give you a fake patient, basically.
Okay.
And you tell me what you're going to do. So it's a 42-year-old female. She's had 3 children. And after every child, she became a little depressed, but she got over it. But now, for the last 2 years, she's been so morbidly depressed. She's had several medications she's tried. She sees a psychiatrist, she sees a psychologist, and has done cognitive behavioral therapy. She has become suicidal, in fact, and she's thought about taking her life. But she has little children. What would you do with this patient? What imaging studies would you get? How would you plan her treatment? What kind of expectations would you give her?
Yeah. Well, actually, I've had a patient very similar to that exact scenario. I always tell people, and actually, I'm putting a YouTube video on this. We do a comprehensive consultation. So I sit down and I go through the symptoms in detail. And then we go through, what medications have you tried and failed? I look for comorbidities. Is she having cognitive issues? Is she having hormonal disturbances? Has she had an endocrine evaluation? Once all that is kind of done, I ask, for example, is she drinking alcohol? We didn't even go into this, but alcohol reduces neuroplasticity, causes depression, and can be heavily negatively impact everything. So let's say she's not drinking much alcohol. How's your sleep? We talk about sleep and those kinds of things. And then we say, okay, you've tried these different medications. Let's consider TMS, transcranial magnetic stimulation. We talk about the risks and benefits, and we went through that in detail here in this conversation with you, of course. And then we actually do a couple things. We do an MRI of the brain, and we also do what's called a quantitative EEG. It's not absolutely necessary that you do those things, but I like to do them. One, MRI of the brain does two things. One, I make sure there's nothing else contributing to her symptoms. A rare case, maybe she has vasculitis, maybe she has a brain tumor, maybe she has something that is rare, but we look for it. And then more importantly, I use that data to actually navigate to specific locations of the brain. So typically, most offices just use scalp measurements to identify the left dorsolateral prefrontal cortex, which is okay. But I actually, as you know, everyone's brain is like a fingerprint. The sulci, folds, gyri are slightly different. The head size is different. So I get an MRI. We have basically kind of like your field. We actually see the MRI, see their brain in real time, and then we do the EEG because the EEG helps me establish a baseline. Usually it shows, for example, abnormalities either in the prefrontal cortex or sometimes in deeper regions of the brain, like the cingulate. And then we talk about that. And then we start a treatment design for her. So, for example, if she has comorbidities with headaches, I design a protocol to address that. We talk about different options. We have the accelerated option, 5-day protocol. Maybe she's coming from out of town. Maybe she's come from the East Coast or wherever, and she can't spend 30 days here, right? We offer her this 5-day treatment, which has greater than 90% success for depression. And we talk about the risks and benefits. We have our MRI, we have our EEG, and then we have her sit down in the chair. We use these fiduciary markers to tell the system where her brain is. We find the dorsolateral prefrontal cortex, we place the coil, and we run a usually theta burst protocol, as you mentioned, plus maybe another protocol to help with her anxiety and one for her migraines. And then she's there for about 10 or 15 minutes of 10 times a day. And after the fifth or the second day, we remeasure what's called the motor threshold. This is to ensure we're stimulating the brain. So we measure how intense we need to stimulate to move her hand. And then we use that to basically stimulate the brain. And then we constantly, every time the staff and I ask her, how are you doing? Are you having any headaches? Did you have a bad night of sleep? Are you feeling any changes? I modify the protocol accordingly. And then after she's done, if she's from out of town, we repeat the brain map, the EEG we call it, after the last session. If she's available in town, we have her come back in 2 weeks and do it. We have her do the rating scales. So I forgot to mention that before we start, we have her do standardized rating scales. For example, we use the Burns Depression Scale, we use the PHQ-9, we use the Montgomery-Åsberg Depression Scale, which is what was used in Stanford's trials. And then we kind of gauge the severity. We have her repeat those same scales 24 hours after the last session, and then come back and repeat them again in 2 weeks. And then we have a follow-up either via Zoom or in person in 2 weeks. So that's kind of the entire process in a nutshell.
Okay. Very cool. So you're getting an MRI. Or is it a functional MRI or just a standard MRI?
Well, right now, we're just doing a specific standard MRI. We have very
Okay.
thin cuts. We actually have a protocol we send to the MRI center. Basically, functional MRI, we have the capability of doing so, but it's added costs. So unless it's absolutely necessary, I don't really do it.
So for the listeners, Dr. Elahi is using something called stereotaxis, and we've used this all the time in the OR. In fact, no neurosurgeon will operate in the brain essentially without stereotaxis. And that's this concept that 3 points in space can tell you 3 points can give you any point in space. So he's talking about these fiducials. They're these little buttons that you stick on the skin and you do the MRI. And those 3 points will tell you where in the brain you are targeting, essentially. And in this setting, you're targeting the dorsolateral prefrontal cortex. So Dr. Elahi actually knows exactly where it is. He's not just measuring 5 centimeters up from the motor cortex or whatnot. He knows the exact gyri of the brain that he's hitting. And that leads to better accuracy and presumed better outcomes.
That's right. You mentioned functional MRI, so I should distinguish. The Stanford trial prides itself in doing the functional MRI to identify the exact location within the dorsolateral prefrontal cortex using what they call the activation deactivation area between the dorsolateral prefrontal cortex and the anterior cingulate. However, they've never shown, there's been no study to compare as a head-to-head trial whether to do that is actually the key component of the accelerated outcomes. In other words, there wasn't a trial showing, okay, let's do it without the functional MRI and compare it with this and see if there's a difference. So a lot of us in this field argue that we don't know if that was a key component. Why not just reduce the cost for the patient? And yes, you can do an anatomical MRI, and we use EEG as a baseline as well. Target the dorsolateral prefrontal cortex, and there are some nuances. If you go more midline, there's some anxiety related to it. If you go more lateral and inferior, it's more anhedonia and depression. And, some of that is research based. And we get the similar outcomes. So, i.e., 80 to 90% or better.
Yeah.
So, I spare the patient as much as I can in terms of logistics, costs, and going back and forth.
So can you give me a range? If someone's depressed, they want the full 5-day theta burst treatment, will their insurance pay for it? And if not, how much will it cost them out of pocket?
Well, good question. First off, 90% of insurance policies cover the standard 30-day treatment.
The 30-day treatment. Okay.
If they show that they've tried and failed medications, they've tried and failed therapy, and they have severe depression. That's a no-brainer, if you will. I think maybe one or two actually are approving the accelerated protocol at this moment. However, I've heard that more and more insurance companies are covering the accelerated now. I asked a couple of them, why don't you? It's FDA approved, it's on label, and they couldn't give me an answer. They said, we just don't. And so that's that. Now, as far as patients coming in, maybe they don't meet the qualifications from insurance. Maybe they want to do the accelerated and their insurance doesn't cover it. The cost is basically between $300 to $400 per session. If you do 50 sessions, that's between $15,000 to $20,000.
Okay. Yeah, I mean, $15,000 to $20,000, it definitely would be worth it if you're stuck in a hole, honestly. But for many people, that might be out of reach. So if they can get their insurance to approve it, just to be clear, the 36-day protocol is not less efficacious than the 5-day protocol, correct?
It is not.
Yeah,
It is not. It is not less efficacious. It's just as good.
just as good. It just takes longer. And that's the
Correct.
one that most insurance programs will approve.
Correct.
Yeah. For most people, I
So,
think the insurance approval is probably going to be the way to go. To get approved by insurance, do they have they had to have failed at least one or two medications?
yes,
They do.
yes.
Okay.
Unfortunately, even though there's no reason scientifically, TMS will work whether you've ever tried medications or not. But for insurance purposes, they have to have tried and failed medications. Now, some insurance say two, some insurance say three. I think one says one. The FDA protocol, the FDA label is only one failed medication. And then some insurance make a fuss about it. You have to have tried different meds from different categories for some period of time. But it's becoming more and more clear to insurance companies that, hey, we're going to save money by approving these treatments. So they're becoming much more flexible than they
Yeah.
were before.
You have to have a long view. You have to be forward thinking, honestly. I mean, put a
Yeah.
patient on antidepressant for the next 2 decades, 3 decades with, erectile dysfunction, weight gain, metabolic syndrome, apathy and poor productivity in the world. And you think about that versus one, maybe two, a couple backup treatments of TMS. It just makes sense from a financial standpoint.
Oh, yeah. Until, as one of my patients said, older gentleman brought his wife who had suffered from PTSD and depression for decades, ever since she was in her 20s, and nothing worked. And for the first time, she saw significant relief. And her husband was so reluctant at first, was so like dismissive. He was convinced afterwards to a point where he came on and gave us a testimonial. And he said, tell your patients you can't afford not to do it because he came from a wealthy background. He had spent thousands of dollars on so many other treatments. This
Yeah.
was the only thing that worked for her.
Well, I'm excited to see more about TMS, and I'm really appreciative that you're out there getting information out about it because we won't know about it unless doctors like you come out and talk about your experience, talk about the literature. Because right now, billions is being made on pharmaceuticals. There's no doubt about it, and there's a whole industry built around depression and dementia and PTSD, making medications that oftentimes just don't work. And here you are, you have a non-invasive magnetic therapy that creates real changes in the brain that
Sure.
lead to improvement in these debilitating symptoms. So I'm very appreciative to you
Yeah.
for that.
I'm very appreciative of guys like you who are putting time in. I know your time is not like, super available, and you're doing this. This is incredible. And I've done some podcasts. This is the first one with an actual neurosurgeon who knows what I'm talking about, who recognizes the field, is very familiar with the field, and recognizes some of these risks and benefits very well. So I thank
Yeah.
you for
Yeah.
being available.
Well, and I would just one thing I want to add on the cost again, guys, I don't do a single surgery that costs less than 15,000. I don't think I do a single surgery that costs less than 20,000. Insurance pays
Right.
for it most of the time. And if insurance will pay for the 36-day protocol on the TMS. So, but that's just to put things in perspective.
Yeah.
And when I do a lot of spine surgeries for degenerative spine disease, it's usually the first of many, or it's the second or the third of many because you get this continued domino effect of degeneration throughout the spine. And unfortunately, we're not curing degenerative spine disease with spine surgery. We're just stabilizing and hopefully creating more quality of life before the next degenerative event comes. With TMS, you're actually fixing broken neurological patterns. And it costs less than any surgery you can do with less suffering. I mean, just think about that. There's no suffering. When I do a spine surgery or a brain surgery, people are in the hospital for a day or more, or many more, suffering, taking narcotics, stool softeners, muscle relaxers. And yeah, their neuropathic pain gets better. And that's very rewarding to see. But they have to go, I mean, they're off work for 6 weeks to 3 months after these surgeries I do, that I'm doing multiple times per week, every week.
Well said, Ravi. My own father had multiple levels of fusion. This is before I even went into this field, and he's still suffering. You asked about my dad. I actually did TMS for his chronic pain as well, and he did
Okay.
see improvement. My mother just had a spinal fracture 2 weeks ago, and she had a one level fusion a year ago, facing another one now. So yeah, it's very, very debilitating and very hard to see.
Yeah. And I'm not arguing against doing invasive therapies. That's what I do for a living. But when you find something that's less invasive with equal or more benefit, pay attention, because that's what TMS is essentially. We're not learning about this in medical school, by the way, too. And no one's teaching them this in medical school. I saw it during residency. A PhD researcher was doing it, and he put it up against my head, and my hand started twitching. And I was like, well, that's pretty cool. But I thought, this guy's just dabbling in a curiosity. That was a long time ago. But yeah, I mean, this is not being taught in medical school because there's really no money for large businesses behind it.
That's right.
And doctors can make a living off of it, and patients can get tremendous benefit off of it. And that's kind of where it stands. How can patients get a hold of you, Dr. Elahi?
Many ways. So they can directly call us. The office number is 949-652-7301. They can go on our website. The website is pretty easy. It's neurospabrain.com. By the way, the word neurospa was my wife's suggestion. Unfortunately, some patients think it's a good idea. Some patients think it's not a good idea. We don't do any spa treatments. It's not a spa, it's a medical office. But anyway, neurospabrain.com. You can go to our YouTube page. It's basically NeuroSpa Brain. If you search that on YouTube, it will be there. We have like 76,000 subscribers. I post educational things on there, similar kinds of things we just talked about, and also patient testimonials, so you can see for yourself what patients have to say. And of course, they can always email us, info@neurospabrain.com.
Okay, and I'll put all those in the show notes, all that information in the show notes. But yeah, this has been tremendous. And if you are listening to this, it might be worthwhile to come back and watch it on YouTube, because Dr. Elahi's had a brain model out, and he's been showing us anatomy on the brain throughout this whole talk. So yeah, it's fantastic, this field, and I'm really excited about learning more about it. And thank you so much for coming on the show, Dr. Elahi.
So it's really my pleasure. And thank you so much for allowing this platform for viewers and listeners to listen to.
Great. Cheers. Thank you.
Thank you so much.
So I hope you enjoyed this conversation with Dr. Elahi and now have a solid foundation for understanding TMS, what it is, how it works, and why it can be such a powerful, sometimes even life-changing option for conditions that are notoriously difficult to treat with medications alone. These are the illnesses where drugs often bring major side effects, inconsistent results, or simply don't work at all. TMS offers something different, and my hope is that this episode gave you a clear window into that world. If you enjoyed the show, please let me know. I genuinely love hearing from listeners. In our next episode, we're finally getting into that deep dive on depression that I've been promising you guys. This is going to be a full exploration of the biology and the mechanisms behind depression. And because the topic is so important and so huge, I'll likely split it into 2 episodes. Episode 1 will walk you through the biological basis, what's happening in the brain, the networks, the neurochemistry, and the full landscape of available treatments. Episode 2 will be a practical, structured roadmap for recovery, evidence-based tools, lifestyle strategies, supplements, therapies, and how they all fit together. And yes, TMS that we learned about in this episode is part of the depression treatment algorithm. I've basically written this series on depression to empower you with clarity and real actionable knowledge. So until then, stay curious, stay skeptical, and stay healthy. Cheers.